What is midostaurin? What are the most common side effects of midostaurin?
So midostaurin is an oral chemotherapy agent. It specifically comes under the umbrella of targeted therapy because it targets a mutation found in roughly 30% of cases with acute myeloid leukemia. That mutation is FLT3, either ITD, which is internal tandem duplication, or TKD, which is tyrosine kinase domain. So around 30% of patients with AML will have this mutation, and midostaurin is an oral agent targeting this mutation specifically. We don't know if it works for other mutations, but it is approved in AML only for patients harboring the FLT3 mutation. What led to the approval was a randomized phase 3 study in which patients younger than 60 years of age who had a FLT3 mutation were randomized to receive intensive chemotherapy, which is standard of care, with 7 days of cytarabine and 3 days of an anthracycline. And patients were then given midostaurin versus placebo. So the comparison was 7 plus 3 plus midostaurin versus 7 plus 3 plus placebo. Midostaurin was given at a flat dose of 50 milligrams twice a day, starting at day 8 and continuing through day 21 of chemotherapy. And then it was added for during consolidation chemotherapy as well. The primary endpoint of the study was to show overall survival benefit with the addition of midostaurin to standard chemotherapy. And the study did meet its primary endpoint, and there was a survival benefit for patients who had received midostaurin compared to those who were receiving placebo. Now, there are different ways to look at how much that survival benefit was because a lot of patients went to transplant as well. But broadly speaking, after 4 years of therapy, patients who took midostaurin had a roughly 6 to 9% chance of living longer than those who had not received midostaurin therapy. Some of the common side effects associated with midostaurin were GI toxicity, such as nausea, vomiting, diarrhea, the elevation of liver enzymes, and needs to be monitored very closely when giving with other fungal medicines or other infection preventing medicines as well.
How are these side effects managed?
Usually you give supportive measure medicines for the GI side effects like anti-nausea medicines, anti-diarrhea medicines. Sometimes you would hold a medicine for a little while, patients would feel better and then restart the midostaurin. And as far as interactions with other medicines were concerned, you'd ideally want to use other supportive medicines from a different class which would have the minimum interaction with midostaurin.
What is the difference between a first generation and second generation FLT3 inhibitors?
Broadly speaking, so FLT3 inhibitors are becoming more and more selective as you go generation by generation, meaning that the earlier FLT3 inhibitors, so there was sorafenib, there's midostaurin now, there's gilteritinib that's FDA approved, there's quizartinib, which was recently published and was a positive phase 3 study. So these are all FLT3 inhibitors. The the more novel the agent, the more specific they are, meaning that agents approved before had more targets in addition to just FLT3. Now, those targets may not be mutations found in AML, but they were just other targets that the medicine would cover, meaning that had a chance of leading to off target toxicity or more side effects. So, a very simple way of saying is that the earlier TKIs would have been more of a dirty TKI, meaning broadly covering several targets. And this could mean that, whether that led to increased efficacy through some unknown mechanism, yes, but that also could mean that it could lead to more toxicity as well. And so the novel TKIs are more FLT3 specific. They also have their own side effects, of course, but these mainly target FLT3, so they may not have too many off-target toxicities and may just have regular myelosuppression, or which is low blood counts and other toxicities, but they may not be effective for other mutations, like let's say some of the earlier FLT3 inhibitors were.
How can a patient tell if midostaurin has successfully eliminated their AML cells?
When you treat people with um, midostaurin, there are different ways to capture response. So, the basic response is whether they've achieved remission, meaning there's no there are no more blasts in the bone marrow, and the person has recovered their white cells, red cells, and platelets. And there's no evidence of disease by sensitive tests such as flow cytometry. So you could do an assay to look for FLT3, which is called leukostrat, which is a PCR basically. And that's how you initially diagnose the mutation at the time of diagnosis, either through PCR or NGS, PCR being a little more sensitive than NGS. So you can use this assay to see if the FLT3 mutation has gone or whether it is present at a low level, which we would call measurable residual disease or MRD positivity. So we think we know that patients who are MRD negative tend to do better than those who are MRD positive in terms of relapse and overall survival. So yes, it does go away, but we now have very sensitive tests, for example, 10 to the power minus 6, like looking at almost a million cells or more and trying to find leukemia cells from those total number of cells. So we see where there's complete absence of leukemia or bad cells, and then we see that there's a small presence, and a small presence may predict for poor outcomes compared to complete absence of leukemia cells.
Who should take midostaurin and how is it administered?
So the current standard is that midostaurin is approved as frontline therapy for patients with AML, so newly diagnosed patients with acute myeloid leukemia harboring a FLT3 mutation, whereas the current indication for gilteritinib is for patients with relapsed or refractory acute myeloid leukemia with a FLT3 mutation. So one is approved in the frontline setting, whereas the other one is approved in the relapse and refractory setting. So patients with acute myeloid leukemia who have a FLT3 ITD or TKD mutation and are also considered fit to receive intensive chemotherapy are the patients where you would use midostaurin in combination with intensive chemotherapy. So, the actual study that led to midostaurin approval had patients younger than 60 years old. In general practice, people above 60 are also consider like we would also give them midostaurin if we thought they were fit for intensive chemotherapy. Some factors that go into determining the fitness of a person for intensity of treatment is uh, age, comorbidities, as well as what their performance status was, probably not at the time of diagnosis, but let's say 2 to 4 weeks prior to the diagnosis. So even if they were, let's say, 65, had minimum comorbidities, were healthy, were doing fine before the diagnosis of AML, you could consider treating them with intensive chemotherapy plus midostaurin. By the same token, if you have someone who's young, but let's say has too many comorbidities such as congestive heart failure, coronary artery disease, chronic kidney disease, then you may not even consider giving them intensive chemotherapy and may consider using a less intense approach, in which case they would not be candidates for midostaurin therapy. It's given orally. It's for the induction cycle, for example, it is started at day number 8. It is started at a dose of usually 50 milligrams twice a day, and it is given for a total of 14 days. So from day 8 to day 21 during induction, and similarly for 14 days per cycle of consolidation chemotherapy. Now, once consolidation finishes, if a patient proceeds to transplant, that's fine. Then they come off of midostaurin. If they don't proceed to transplant, there is some data you could use midostaurin maintenance, but that's not as mainstream as there are other agents now approved for maintenance, such as oral azacitidine. So, in that scenario where they don't proceed to transplant, one can consider keeping them on midostaurin if they tolerated it, but that wouldn't be considered standard of care at many centers. So while it's being given with induction and consolidation, it's used with other drugs. But as if you were to use it at maintenance, you'd probably use it as monotherapy. So for example, in induction, it is given with 7+3, which is the standard induction backbone in the United States, and in consolidation, it'd be given with something we call Hydac or high dose cytarabine. So those are the common drugs it's combined with.
Can midostaurin cure AML?
So, midostaurin can help in curing AML for a subset of patients. Now, how is that? So for patients with FLT3 mutation, ITD, they're considered they're considered more intermediate to high risk patients. So we know that perhaps chemo by itself isn't sufficient to keep them in remission for a long time, and most of these patients would benefit from consolidation with a stem cell transplant down the line. Midostaurin may help in getting these patients into a deep remission and then allowing these patients to proceed to transplant in a deep remission, which could ultimately cure a subset of these patients. So you could think of it as a bridge to cure, but it would be hard to say that by itself it would cure leukemia. There is a lot of research being done to improve the outcomes of patients with AML with the FLT3 mutation. So, for example, gilteritinib, which is already approved in relapse refractory setting, a lot of these FLT3 inhibitors are being used as post-transplant maintenance. And then just recently, there was a positive study leading to a survival benefit with another FLT3 inhibitor called quizartinib compared to placebo. Things are improving by finding novel agents which are even more effective than already approved agents, and hopefully with a side effect profile that is much more tolerable.